Angelman syndrome was first discovered by Dr. Henry Angelman in 1965. Initially, it was referred to as happy puppet syndrome, but was later changed to Angelman syndrome.
About 1 in 10,000 to 20,000 adults and children are living in the United States with Angelman syndrome. Symptoms typically are not apparent immediately at birth, and therefore a diagnosis is usually made between the ages of 1 and 4 years old. Angelman syndrome affects males and females equally.
Angelman syndrome is a genetic disorder. The following abnormalities can trigger Angelman syndrome. A deletion at the UBE3A gene of the maternally inherited chromosome number 15 is the number one cause of Angelman's. Uniparental disomy. In this case, the baby inherits both copies of a section of chromosome number 15 from the father, rather than one from the mother and getting one from the father. Imprinting defect. This is when the UBE3A gene from the mother of chromosome number 15 is turned off. Again, here the mutation is referring to the mother's UBE3A gene being mutated.
Chromosome deletion. The child is usually more severely involved with microcephaly, seizures, motor difficulties, and cognitive and language impairments. When there was a UPD, the child has better physical growth, less movement disorders, and less seizures compared to a child who has had a chromosome deletion. For a child who had an imprinting defect, this child will have the highest cognitive, language, and motor abilities compared to any of the other types of mutations. This child may even be able to use simple sentences. When there was a mutation, the child will have intermediate levels of microcephaly, seizures, motor difficulties, cognitive abilities, and language development.
And symptoms include motor delays and movement disorders such as ataxia, flapping movements, subtle tremors, low trunk tone, and high tone in extremities, along with an abnormal gait.
Other signs and symptoms include developmental delays, intellectual disabilities, seizures, scoliosis, nystagmus, and strabismus.
That's all there is to it.
Facial features include wide mouth, widely spread teeth, tongue protrusion, pronounced chin, squinting appearance, microcephaly, drooling, and children appear to be smiling and happy at all times. They often have sudden outbursts of laughter in inappropriate contexts. Precautions include seizures, malnourishment in infants, obesity in adolescents and adults, fatigue, and impulsivity.
Here we go.
Prognosis. These adults with Angelman syndrome will experience a lifespan decreased approximately 10 to 15 years. They will require lifelong care as well. Seizures will continue from childhood into adulthood. However, ataxia will improve. Adults with Angelman syndrome experience decreased excitability as well as less sleep problems. Adults with Angelman syndrome will also continue to have speech and intellectual impairments.
In order to make a diagnosis, the doctor will look to see if the child has developmental delays and other typical signs of Angelman syndrome, such as problems with movement and balance, small head size, flatness in the back of the head, and frequent laughter. However, this condition is often misdiagnosed as autism or Rett syndrome. It can be confirmed by taking a blood sample for genetic testing in order to reveal the chromosome defects related to Angelman syndrome.
Treatments include behavioral therapy for sleep disorders, for example, to adhere to strict bedtime routines, surgical correction of strabismus or scoliosis, early intervention to ensure the child reaches their full potential.
Medication treatment includes clozapam, which is an anticonvulsant used to prevent and control seizures, as well as laxatives, which may be used to treat constipation.
School performance will require a one-to-one aid, accommodations, and modifications.
Angelman syndrome results in abnormal sleep-wake patterns that varies with the individual. Some children will only sleep a couple of hours a night. Most of those with Angelmans do not take naps as typical children do. This can disturb the school schedule or therapy sessions, and it is exhausting physically and psychologically for the parents and caretakers.
Children with Angelman syndrome will oftentimes experience a decrease in ADL performance in feeding and eating, bathing, toileting, and dressing. Oftentimes, this decrease in independence is a result of ataxia, tremors, decreased attention span or other cognitive deficits, visual deficits, decreased trunk control, or a decrease in the ability to coordinate tongue thrusting and the suck-swallow movements required for feeding.
That's all there is to it.
Individuals with Angelman syndrome, regardless of the genetic subtype, should receive and will benefit from occupational therapy. OT can help to enhance independence and self-help skills like eating and dressing, improve support for play and leisure, improve regulation and sensory processing, develop fine motor and pre-writing or writing skills, address the necessary school modifications and accommodations, and assist in IEP collaboration.
Just stomp your feet and clap your hands. Come on, everybody.